Good afternoon and welcome to the Alliance for Home Health Quality and Innovations webinar on Positioning for Partnership, Home Health Agencies Building Key Relationships for Success. My name is Teresa Lee and I'm the Executive Director of the Alliance. And by way of background, the Alliance was founded in 2008 and is dedicated to the mission of leading and fostering research and education on the value that home health care has to offer to patients and the entire U.S. healthcare system. The webinar today will focus on how home health agencies can build successful relationships as the healthcare delivery system evolves. We're so very fortunate today to have as our guest speaker, Brent Feorene of Health Dimensions Group. Brent has over 25 years of experience in identifying and addressing the strategic and management issues in physician-led, post-acute, and community-based services and programs. His clients have included traditional acute care providers such as health systems and ACOs, managed care organizations, home care agencies, and community-based providers and service agencies. Among his engagements, Mr. Feorene has worked collaboratively with these clients to create integrated delivery models that bridge location and level of care to ensure timely access to appropriate services and high-value care delivery. Just a few housekeeping notes before we get started. First, Brent will speak for approximately 45 minutes and will leave the last 10 minutes to answer questions. Please note that this is a webinar and we control the slides on our end, so don't be surprised if you're not able to flip ahead. Your lines will be on mute, but you can submit questions throughout the webinar to be answered during our Q&A period through the Fuse webinar software on your computers or other devices. You can send a question to the speaker to be answered in that period by sending a question to me, Teresa Lee. Finally, we will also be posting the slides on the website after this webinar. We're also recording the webinar and we'll post the playback on the Alliance's website when it's available. And with that, I'm going to turn it over to Brent.
Thank you, Teresa. It's really my privilege to be presenting today to the Alliance via this webinar. And I feel that, no portion of the healthcare industry is probably in greater turmoil or challenge than home health agencies. And I think that's kind of funny because no other industry is better positioned to provide the kind of value that we're looking for today. You provide care in the home, you're one of the most cost-effective ways of delivering care, and you have outstanding outcomes. So I think home care is in a unique position. If you can capitalize on the turmoil today and move forward, you're an incredible asset. So today I'd like to talk a bit about the environment we find ourselves in to kind of provide that common framework of learning, and then talk about some of the early takeaways we have from this environment, from things that are happening today. And then possibly offer you some ideas on making your case, fitting yourself in, and doing it all because your plates are very full today. As Teresa indicated, we encourage conversations throughout the webinar, so please feel free to chat message her with a question or a comment, and then we'll have time at the end as well. Well, briefly, that's me. Teresa already did that. Health Dimensions Group is a post-acute and senior living consulting firm. We really work with the breadth of post-acute and senior living from ACOs and health systems through independent living and senior housing, offering strategic consulting, operational performance improvement, and for some facilities, we do interim and long-term management. I think this quote really sizes up healthcare today, and particularly home health agencies. If you think you can run your company the next 10 years the way you ran it the last 10, you're out of your mind. That's credited to the former CEO of Coca-Cola. So we have to change the way we view the world because the world has changed. And I'm going to go through what I consider to be among the top 5 trends of integrated care that really are affecting you today. One is this movement towards value. Second is the increasing recognition of the social determinants of care, which you all face every day when you go in the home. Secondly, engaged intervention. I always think this is from the National Transitions of Care Coalition. It's really, I think, effective way to view the interaction with the patient. It doesn't have to be a transitional interaction. It could be any interaction. It really defines how to bring value to that interaction. We talk about integrated care partnerships and some of the relationships that are crossing silos that are really showing promise. And then this idea of strategic pivoting. Organizations are trying to reposition themselves to kind of fit into the new world, and we'll talk a bit about that here as a major trend. So this movement towards value, you're all well aware, we're moving away from payment for services delivered with little financial risk and no quality measurements to really an environment where we're being paid for value delivered, very outcome and performance based. Some of the developments in that area, CMS, the Medicare wants to move a great majority of their service delivery to an alternative payment model. The link to quality, 90% by 2018, and alternative payment models will be 50% by 2018. Among the developments also is the Healthcare Transformation Task Force, where this collaboration of large health systems and payers, purchasers being employers, and other stakeholders have come together, and they're trying to shape the discussion on the movement towards value-based care that reflects their particular constituencies. And they're committed to help move that business to 75% value-based by 2020. One of the reasons the push towards value is the variability in cost in the initial post-acute setting, the first post-acute setting after discharge. You can see it is widely variable, with home health among the most cost-effective. Bundling, obviously a huge push in value-based. Model 2 and Model 3 have been the most predominant. This graphic just provides you a little bit of background on what's included in the various models of bundling, how payment is done. And you can see it's all retrospective except Model 4, which we've seen very little of. You all are most likely involved in 2 and 3. A lot of the push has been, we feel, to really make Model 2 the most, because it ties the acute setting to the post-acute setting. And you'll see more and more Model 2, in our opinion. Going forward, bundling will only continue to grow. Medicare BPCI is the current bundling initiatives you know of. There's commercial development, state Medicaid, Medicare Managed Care, Medicare Advantage is moving into bundling, and the recent announcement of the Medicare Comprehensive Care for Joint Replacement mandated bundling in the 75 metropolitan areas starting January 1. And personally, I was a little shocked how quickly they released that, given the fact that not all the data or findings are in from the BPCI bundling. Regardless of where the bundling comes from, be it commercial, Medicare Advantage, CMS, there's components of bundling that are consistent. It's a defined population for a defined period with a target of quality target and a price target. What does differ is the payment. Most of them are retrospective in their payment methods. You get paid traditional fee-for-service with a retrospective adjustment at the end, and some of them have included downside risk in addition to the upside risk. We're predominantly seeing retrospective today with upside, very limited downside. This is just a graphic from Arkansas. Point being, Arkansas is moving towards bundling in their Medicaid program, and New York State is requiring that 80% of Medicaid payments be made under some value-based framework within 5 years. Kind of that train's left the station, I guess, is the point we're leaving this slide with. Commercial plans, over the next 5 years, 35% of health system revenue will be in some form of a bundled payment coming from a commercial payer, and 24% of health plans are currently implementing some form of bundling. It's a movement that really, I think, is not going to decline in momentum. And then the CMS mandated bundling effective January 1 that I previously mentioned. Teresa and I debated whether to include PACE. We thought it made sense. PACE has been around a while. There have been some recent developments in PACE that I think are noteworthy for you. Just for those that are maybe not as familiar with PACE, it is a population health program that is comprehensive, including medical, social, and preventive. The participants have to be at a nursing home level of care, so these are fairly sick and elderly patients. And it is an integrated financing arrangement, which we're trying to show here in the graphic. It includes Medicare, the state Medicaid, Medicare Part D, And in some instances, individuals do privately pay to participate in PACE. PACE is successful when they have the scale. You have enough eligibles that are interested in joining PACE, when the state Medicaid rates work, and when the population health capabilities of the program are very strong. So PACE has had a kind of a mixed success record in terms of profitability. The outcomes are typically very good because it's very much subject to state rates and their ability to find scale with the eligible patients. There's PACE in 32 states, serving about 34,000 participants, and there is a variety of types of sponsor organizations, hospitals and health systems, and community organizations being the most predominant. We are now permitted to have for-profit PACE. It was a not-for-profit model only. CMS is allowing for-profit PACE, and we are personally getting interest from venture capital firms in looking to invest in PACE to help scale it, one, and two, to take some of those skills and capabilities and possibly applying to other eligible populations outside of PACE, because PACE is really the gold standard for population health. So for home health, that means you might be able to participate in some of these for-profit PACE developments because they're going to be looking for providers that can help deliver the care in the community outside of the PACE setting as for-profit money gets involved in PACE. And then finally, just some basic criteria to be in PACE: 55 or older, in a PACE area, PACE state, nursing home eligible, and able to live in the community safely. And you can see the enrollee snapshot. It's a fairly chronically ill and frail population. The vast majority, 95%, would be considered dually eligible in their states. Another development on value-based is this movement towards post-acute medicine. That's taking a medical provider out of the acute setting, out of the outpatient or office or clinic setting, bringing them to the location that the patient is. So we're tying the delivery to the patient's needs, their place of residence, targeting patients that are not well served by traditional settings. So this is house calls, this is medical house calls, which many of you may be familiar with in your markets, SNFist programs, transitional care. One of the differentiating factors in post-acute medicine is we're wrapping the population health, patient-centered home model around the patient, but in their place of residence where they're at. So we're talking about other supportive and community-based services, not just straight medical care delivery. ACOs, another major movement. There are 446 Medicare ACOs currently in 47 states. You have the breakout down below. This is there's been some concern of those dropping out of Pioneer, but those really weren't ready for that level of risk initially. We don't see any slowing down in momentum. A lot of the MSSP ACOs are doing quite well, and the remaining Pioneers have been successful as well. So we see this as a continued trend and a trend that you need to be aware of in your particular market. The duals, many states have a movement towards mandated dually eligibles. That's because of just the size of the population. 1 in 5 U.S. residents will be elderly in 10 years, and of those, about 25% are expected to be dually eligible. And that's really important because the dually eligible have a much higher incidence of disease and of bringing socioeconomic issues to the game, so to speak. So the prevalence of these socioeconomic issues and higher prevalence of chronic disease really has an impact on the cost, the utilization, and how you manage that profile. And as I mentioned, several states are pursuing alignment demonstrations of some sort. The green are a capitated model, and you can see the blue is MOU signed but nothing executed yet, and the Oklahoma then has not pursued anything yet, and the yellow golden is not moving. There is a trend here. It's a mixed message. In some instances, PACE and dually eligibles are a bit competitive. We'll see where this all washes out. Impact Act, you're all, I'm sure, very familiar with this, and its desire to have standard data elements and data reporting across the post-acute setting. I think the message here is that ultimately they'll likely lead to a change in post-acute payment to an outcome-based and site-neutral. I've read a few comments that they believe facility-based payments will be one, so IRS, SNF, and LTAC, then home health will be another, though that's certainly still open for discussion. But the point being, common data set, common reporting, and a different payment methodology, likely based on outcomes. I won't going into impact anymore. Another important trend for you, important development for you, is the Medicare spend per beneficiary. They're looking at the efficiency of hospitals' care delivery from a cost perspective. So they're looking at the hospitals 3 days before the hospitalization, and 30 days after discharge, which involves what you all do, which involves SNF and then discharge to home with home health. So that whole snapshot, Medicare is going to look at how the hospital did across that. And what does that do? That drives the health system to look to align with post-acute partners that really can deliver the care quality, the care value that's needed for the hospital to be successful in the Medicare spend per beneficiary. You yourself have a value-based program model over the beginning in 16 and running for the next 5 years. The states there are listed at the bottom. I'll just, in interest of time, will continue. The next area, I think I've driven the point home on the value-based environment. It's a trend. It affects many different aspects of healthcare. No one will be exempt. The next point I think I'd like to make here is the social determinants of care. This graphic is actually 16 years old, and it's basically saying that clinical care is about 10% of the total spend. So if you take out genes and biology at 10 and clinical care delivery at 10, 80% is outside the scope of heredity or care delivery. So the importance of socio and economic factors, the importance at 40%, the importance of personal choices and health behaviors, 30%. So patient education, empowerment, buy-in, and the physical environment. You all are in the home. You understand the home environment. You can help educate, inform so they make good choices, and you can help working with others address some of the socioeconomic issues. The engaged intervention I had mentioned earlier, these 7 essentials are from NTOCC. I still think it provides a very nice framework for every time you touch the patient: medication management, transition planning for the next step in the care delivery journey. Is the family and the patient engaged and educated so they can make smart choices? Are the health providers engaged? Is follow-up care determined? Do we know the next step? Is information being appropriately transferred back and forth? And do the providers in that chain, are they sharing accountability for the outcome? Questions to ask as you touch the patient, as you build relationships with other providers. This graphic, not meaning to intend that the acute care settings are the center of the universe, though sometimes I think they might think that. It's to say that I think for the foreseeable short term, the acute care setting is probably going to be the place of engagement with the patient for what we're looking to improve outcomes, improve cost profile. But in order for that acute setting to be successful, they need a really strong continuum wrapped around them. They can't do it alone, and you're an integral part of that. Home health, the care transitions, addressing the psychosocial issues, the technologies. So the activation point for the patient might be the discharge from the acute care setting, but that's not the end of it. And the importance to achieve the population health goals we have, we need to wrap these other services around it, and you're in an excellent position to offer that. Partnerships. There have been partnerships of possibly odd bed fellows emerging because of the need, the understanding of that previous graphic, that the acute care setting isn't it, and we need to work together to achieve outcomes. Some of these partnerships in general categories are preferred post-acute networks. Many health systems or ACOs are looking to develop a preferred network of home health agencies, a preferred network of SNFs, skilled nursing facilities, that they can work with, that they'll discharge to, that they'll invest in and share data, improve the care delivery, and improve the cost profile. There have been joint ventures that are developing. Interlude is a joint venture in Minneapolis between a large health system and post-acute providers to build a really state-of-the-art skilled nursing facility and actively engage a preferred network of home health agencies for when the patient is discharged from the SNF to the home. Ascension Health and Envision, they've hired Envision to manage their home health and hospice assets. Ascension being a large system that has a lot of home health and hospice assets nationally. Envision, a for-profit company that specializes in ER staffing, ambulance, home health, and house calls, is managing Ascension Health's home health and hospice assets. There have been an increasing and growing interest in CCRCs and other forms of senior housing partnering with PACE to control both the physical residential environment while delivering all that PACE has, as I've described earlier. And Humana and AMC Health. Humana's chronically ill, frail, elderly division is working with AMC Health, which does a lot of telehealth, teleprompts into the home to gather data information, check in with the patient daily. That's a development. And then finally, this idea of a post-acute network alignment, pack to pack, meaning post-acute providers coming together, home health, SNF, most predominantly, to form a network that could then approach an ACO or a health system that we can provide the care for you in the community. We can be your preferred network. More of a proactive approach than a reactive approach. This is just one diagram of how a post-acute care network might work. The PACN can have a membership, those are the owners, and they can contract with other vendors that's needed. It could be community-based services, it could be oxygen, it could be DME. But the post-acute care network has some form of a patient intake, patient management, so that hospital or ACO or MCO there in the orange box at the top can make one call to a care manager, accept the patient in, and get that patient to the right setting, be it SNF, home care, possibly hospice, and ultimately back home. We find that there are some essentials to a post-acute network that do breed success. One being a standardized referral protocol. How does that patient get from the ACO, the MCO, the health system into the care management of the post-acute care network? Clinical reporting back on outcomes, proving the post-acute care network's value, tracking the patients that are accepted and their outcomes, and then ongoing meetings and communication to share data, to share best practices, to address issues, so the program, the post-acute care network relationship with its ACO, MCO health system really flourishes over time. This slide shows that health systems need strong post-acute partners because in most instances, hospital-owned post-acute capabilities don't do so well financially for a variety of reasons: cost structure, scale, number of patients served, whatever it might be. But you represent in home health a fairly compelling, at least financial benefit to a health system that would want to partner with you. This graphic, in the end, just says we're looking to create that healthcare neighborhood to wrap around the patient, the home-limited patient that you all are serving, so that we can have the best outcomes, the best cost profile. And there's a lot of players in that home health neighborhood. Not all of them are going to work with every individual patient, but this is the neighborhood that needs to wrap around the patient. Because of the developments in the first four trends, there's been a lot of competitive dynamic shifts in the post-acute care industry. This race to align, to be in a network or to create your own network that can then reach out to an ACO or a health system. Markets are beginning to become dominated by regional providers. We see consolidation slowing down, and really the squeeze reimbursement and regulatory requirements are putting a lot of pressure on profit margins and challenging the industry. So some of the responses that we're seeing in community-based care would be national home care investments at things like hospital at home, medical house call programs, care coordination. These tend to be very regionally based, in which they select certain markets where they have a nice asset distribution where they can really provide a comprehensive continuum of care, and they can work with health systems in those markets. There's a growth in care management companies focused on medically complex patients and creating these post-acute care networks. A lot of them have worked into the bundling, like the Remedies and the NaviHealth. National providers pursuing exclusive contracts with commercial payers for particular surgeries. Boeing, I know, working with the Cleveland Clinic, among others, trying to save cost and ensure strong outcomes for their population. And there's been a lot of technology developments, from the handhelds that allow personal care aids in the home to track social determinants quickly and report back to an RN case manager, to telehealth, to a lot of other technologies that bringing into the home and allowing more instantaneous access to data and more quick decision making to ensure that situations don't exacerbate. Home health and SNFs forming these networks to position as post-acute coordinators, and payers crossing over into the provider side of the equation, acquiring either care delivery or care coordination capabilities, or partnering with health systems in very tight relationships, blurring the line between payer and provider. One way to think of yourselves as you assess your environment, your situation, is this concept of a solutions provider or a vendor. And I'll talk a bit about both and why a dual strategy really is the best place for you to be today. So a vendor provides a service in a more traditional manner into the industry. So you're providing skilled home care and therapies in the home. And that is a high volume, low margin, high efficiency business. So to win in that environment, it's large, geographic, dominant providers or health system providers that are of value to the system and are sustained. And those that will win in this battle would be low cost, high volume, and those that can prove their quality and their outcomes with verifiable data. Now, contrast that with what I call a solutions provider, which still would provide home health, skilled nursing, and therapies, but would be in a position to kind of own the patient for a period of time and go at risk for cost and outcomes. So there you're building capabilities and strategies to care coordinate, to manage risk, to collect data and report and modify not only your care delivery, but also report back to your partners your outcomes and your performance. So some early learnings from these trends in integrated care. First, hospitals and physicians are forming new partnerships with post-acute providers. They're discussing quality with their providers and looking to narrow the networks to a preferred relationships that they can invest in. While patient choice is always maintained, oftentimes they can direct patients because they say, we work with this preferred group, we've invested in them, we're working collaboratively with them, we can continue to follow you and ensure some level of cost and quality. Utilization is changing. This is specific to bundling, but for an analysis of some of the early results in bundling is the use of institutional care delivery has dropped from 66% to 47% of the episodes. However, the use of home health stayed about the same, didn't pick up any. So there's less use of post-acute in total. So the total spending for episodes with post-acute care fell in comparison to their base period because of this trend. Another early learning is post-acute providers are redesigning how care is delivered, care transformation, if you will. Not that all of these boxes are occurring at all providers, but these are some of the new developments that we're seeing in care delivery transformation. So increased use of palliative care, particularly in the community. I mentioned telehealth already. Increasing care coordination role, health coaching, stratifying risk among the patients that you manage to know who needs more attention than others, who's likely to have a readmission or an incident, post-acute medicine, patient education and teach back, variety of ways. So asking yourself, what is your agency doing to redesign the way care is delivered by your agency? Another early learning is strong care coordination throughout the episode. Handoffs are clean. We understand what's happening in the next step. We've selected a provider that we trust in that next step. It also includes, as I mentioned, stratification, patient teaching and activation, engagement with primary care, and utilization of telehealth. So the coordination has really strengthened and grown across the episode. Can't do the outcomes and the cost profile if you don't. Now, Teresa, I don't know if there's any questions at this point.
No questions as of yet.
Okay.
But I mean, I actually have a quick question, if you don't mind my asking.
Sure. Mm-hmm.
So you had a slide, I want to say it was slide maybe 33, where it's sort of a diagram of the post-acute care network. And
Sure.
you've got the hospital, ACO/MCO, and then you've got the post-acute care network. And then you've got two boxes that kind of sprout off of it. One is tiered membership, and there's a solid line, and one's a dotted line to contracted vendors. I'm wondering what you mean by tiered membership. What does that mean?
Well, in some instances, all the owners may not be capable of attaining assuming the same level of risk or making the same capital contribution. So you may have a level 1 owner that has a higher investment, more risk responsibility, and you could have a level 2 owner that has a lower investment in the network but is still an owner. This allows ownership by a more diverse segment of post-acute providers, and doesn't exclude some providers that may want to be at the table, add value, but don't have the resources to commit at a tier 1.
I see. It's not strictly sort of eat what you kill. There's a proportionality to the investment and any of the network profit or losses. Is that right?
That's right. It would be proportionate to tier level. Yeah.
Got it. Okay, that's helpful. I was just curious as to, whether that was also referring to sort of the narrow networks and, whether one might be preferred over the other by the hospital, ACO, or MCO as well. But it sounds like it's just the structure of the network.
That's right. Allowing a more for diverse ownership base. Typically, when the post-acute care network forms, the providers don't tier themselves in terms of preferred or second tier. Everyone participates in delivering care and being available to the ACO or MCO as they discharge and utilize.
Got it. Okay. All right. That's helpful. Thank you. Do you want to keep going on making your case?
Making your case. So the world's changing. A lot is happening in your world. There's a lot of potential responses that would be unique to your market and your particular situation. So how do you make your case? What do you say to an organization in your market so that you can talk? They would be interested in speaking with you and working with you. Well, you got your value-based checklist. So are you knowledgeable about value-based transformation that's in your market? Who's in a bundle? Which ACOs are there? What's happening in your market? And what are their pain points, and how can you solve those pain points? Do you have the data and the ability to analyze that data to articulate your value proposition? What do you do well, and can you prove that you can do it well? Are you looking at the way care is delivered, the way you operate your organization, so that you transform it to be highly efficient and very cost effective? Have you spoken to your major referral partner, health systems, or payers about your value proposition? And can you credibly discuss pathways for implementing a relationship? How would you go about it? You work with your partner to define that, but can you come out and talk to them about your approach to building this relationship with them? So first, in defining your proposition, certain things that will be looked at, certain areas will be looked at, is your ability to manage the readmissions. And do you have telemonitory and medical management capabilities to manage that patient in the home and prevent that readmission? What does your patient outcomes look like relative to peers? Not so much your input or your process. Those measurements are declining in importance. It's assumed that's in place already. But your outcomes relative to your peers. Do you perform better? And what's your ability to manage an episode, possibly across multiple settings, collaborating with acute care setting, collaborating with a SNF setting, and helping manage that patient from acute to SNF to home. What data should you focus on? Well, the star ratings, they're not perfect and they're not the be all or end all, but they still matter. We find that in most instances when the health system wants to look at a preferred SNF network or a preferred home health network, they do ask about the star ratings. Other factors are considered: geography, willingness to take patients, outcomes, but the star ratings continue to matter. Your new measures as of July of 15: rehospitalization and emergency department use. Many health systems are looking, just to mention, many hospitals are looking to reduce admissions from the ED if they're in value-based relationships, and they're looking to take some pressure off the ED in the first place. So is an ED diversion to home using your organization a program that a hospital that you're currently working with would be interested in? And what might that look like? Differentiating yourself as a preferred provider. Know your performance history and benchmark it against metrics: readmission rates, cost, ED usage. What's your quality? Key indicators here: wounds, falls, infections, patient and family satisfaction. And then, to a lesser extent, the process, the care transitions, the care pathways. And most referral partners, most relationships are less concerned about process now and more on the outcomes data around quality and cost. And position yourself as a solution to their pain points. You could, and this still applies to a vendor or a solutions provider, because a vendor can still provide a service, a very effective service that will offer a solution, quote unquote, to your partner. So know your upstream providers and payers' needs. So looking at discharge volumes, the length of stay, readmission penalties, Medicare spend per beneficiary, what are their pain points? What are they struggling with, and how can you address those pain points? Program participation, if they're in an ACO, if they're be an MSSP, a Pioneer, or into the bundles, they'll be interested in talking to you. And then finally, managed care. What's the penetration of your primary providers in managed care? Are they developing any unique programs with select preferred providers? What's happening in your market there? Potential partners for home health. Those SNFs involved in Model 3 bundling may not be pleased with their current partner. They may have some issues with readmissions, so or they may be considering moving into a bundle. I think they're a very viable candidate to be a partner with you. Medicare Advantage, you can influence many of their 5-star ratings. Medication review and adherence, fall risk, diabetes education. By achieving those marks, you can improve their 5-star measures. And this is something that oftentimes is overlooked in that payer home health relationship. You can add value. And then finally, ACOs and health systems. Readmission rates, obviously still a big issue. And then I mentioned ED diversion to home to prevent the admission if that's part of what the health system's looking to do, if they're in that situation, or even to decompress that ED, which is often just overwhelmed with what oftentimes can be social admissions because the ED physician doesn't have an alternative but they admit this chronically ill, frail elderly, even though they could go home with home care. This is just to drive home the point that readmission reduction is a major opportunity for home health agencies to shine. As you can see on the right side, the drastic reduction in episode per spending without an acute care readmission. So the blue is with a readmission, and the golden, the brownish, is without one. And on the left, we see the still high levels of readmission rates through the end of 2012. Some of that's gone down, but I think the point's still well taken that the cost to have a readmission is very high, and the penalties there too and only increasing. So you can really have an opportunity here to shine. So pulling it all together, I mentioned that the solutions provider and vendor, but there's a dual strategy here. Well, where you will really do both. You'll continue to provide the care, the service as a vendor. That's what you do. That's keeps the lights on, pays the bills. It's the core of your business. But you'll begin to develop those relationships and capabilities, find those partners, find those pain points, develop those skill sets to offer that solutions provider. Because you'll really be doing both. Position yourself over time when more and more care is value based to be a solutions provider. So to get there, you're looking to grow a scale. You're looking to ensure you have a streamlined, efficient culture, consistently evaluating winning and losing capabilities. You don't have to do it all. What do you do well and are very effective at? Great outcomes, good cost profile. As a solutions provider, what are the package solution or solutions that are needed in your market for your referral sources? What do you need to buy internally to fill out a capacity or capability or to vendor out a service capability? It could be data analytics. It could be care management. You want to begin to develop the care coordination infrastructure to own that patient over an episode. And finally, to do both, you really have to have the dedicated leadership that understands the interrelation of the two and the importance of the two, a clear vision articulated throughout your organization, and alignment of the appropriate resources so that you can achieve these ends. So where do you invest in the future? Where do you put your time and energy? You're running a home health agency. You're being successful in delivering care and services. Well, we feel that network alignment and development is important. Whether you choose to work with other a SNF to create a post-acute care network that can then approach a system or an ACO, or the health system or ACO in your market is actively developing a preferred network, you need to get involved in those conversations and invest in those conversations. Care transformation, not done overnight, but what aspects of that care transformation slide that I put up are appropriate for your organization and are you already doing? You plan to begin. Where is your care transformation at today? Care teams, interdisciplinary teams, this is both working internally and as you develop your network alignments and partners, working with them to have the interdisciplinary care team that addresses the patient's needs. Technology, where are you with analytics, data capture, data reporting, analysis and reporting, your EMR and talking to other EMRs, and telehealth, how are you using that in your day-to-day care delivery? And then finally, all members of the care team are very important, but in this time of transformation, are you engaged with local medical leadership at that health system or ACO, the doctor that understands what you do? As I said in the beginning, you're delivering really the best cost profile in the location preferred by most people at a great quality service. Who are the physician leaders at your target referral partners, your target partners that understand that? And are you engaging them in that conversation? And then internally, look inside, evaluate your ability to add value around your clinical services, those that you do exceptionally well, those that you may not want to emphasize as much. Are you operations? Do you have the talent to do this? You know, what took you here may not get you to the next level. What are your competitors doing? What are payers looking for? What vendors can you align with that can assist? And do you have access to investment capital to do this? What are your options there? And you know, we're clearly aware that you really have one foot in two different canoes. So it's a challenging time to manage both. And healthcare hasn't traditionally been in a situation where really there's perverse incentives now with fee-for-service and risk-based. You're almost living in two worlds. So this is a very careful navigation time for you. Understand, we're repeating a few themes here, but I think it's worth it. Understand your market and where you sit in it. I'll go back. Sorry about that. Where are you with care redesign? Are you selectively targeting interventions around that? Your knowledge of quality and utilization metrics internally, and your comparison to where you stand in your market to your peers. And getting a seat at the table, showing so you can demonstrate because your value proposition. Because if you're not at the table, you're not part of the conversation. You're engaging the physician. You're looking to have the data and understand the pain points. And I just like this comment. I'm not interested in minimum risk. I want long-term gains without risk. And so taking risk, both in the sense of care delivery and financial risk and business model risk, new things, new ways of approaching your market, is avoiding risk is not an option in the future. You have to be able to take the business risk and then the clinical financial risk over time. Okay. And that's the end of my prepared remarks. If there's any questions in the chat box, be more than happy to take some. And as Teresa said, the recording and the deck will be provided after the webinar.
Right. So thanks so much, Brent. And as Brent mentioned, there's a chat box. So if you're looking at your screen through the Fuse webinar software, there should be a chat box towards the bottom right, that you can click on so you can enter a question if you've got any. But in the meantime, I'll just go ahead and ask Brent you a question. I think that, to your point, we've got sort of a foot in each canoe, and there's definitely a lot of really significant change going on. My question is that it does feel like, particularly in the context of ACOs and, bundled payments and, maybe even just in the context of hospital readmission reduction programs, that there are a lot of sort of relatively new players going into the home, beyond home care physicians, beyond home health agencies. So, for example, I'm thinking of, for example, community paramedics, EMS providers that are now providing home visits that sometimes look a lot like what home health nurses do. Or even just, hospital nurses and nurse practitioners, either sort of following the Coleman model or the Naylor model and going into the home. So, I know you talked a little bit about building out networks, like post-acute care networks, but I'm wondering how you've been thinking about, or how you've been advising your clients on how to think about the growing number of stakeholders that are trying to either physically go into the home with the patient or are reaching out and doing different kinds of care management via telephone or telemonitoring, or maybe some combination of all three.
Yeah, it's a very good question. I think what's driven a lot of the community paramedicine and the Coleman model is that the home health has been locked into this episode payment, which unfortunately allows you to only deliver the value you have when there's a skilled episode prescribed by a physician. So they're kind of filling these needs. So home health's ability, I think, to work with these other types of providers is probably a very efficient way of approaching more value-based relationships. So if the home health continues to provide episodic care, the EMS can do visits to those individuals, for example, that may not qualify for an episode, but they could be tucked in after discharge to see if they have their meds, if there's food in the refrigerator, things like that. I think, again, with the Coleman model, we're talking about a couple of phone calls and possibly a home visit outside of the traditional episode. I think as that episode gets softened a little bit, or the structure released, so that home health can actually, within value-based at-risk arrangements, you're going to be able to either deliver that care, or more likely, more cost-effectively, to collaborate with others to deliver that care.
That's what I was thinking too. Yes, that opportunity for collaboration, and that sort of by connecting the dots. I mean, there might be really good reasons why you've got these new entrants as stakeholders in care at home, but is it possible that we can leverage the competencies of each of these different providers. And it may be that some of these new entrants may not prove to be valuable in the long run. That's entirely possible. But I, like you, have been thinking, is it possible to kind of connect the dots here so we can kind of get the best of all parties,
Right. So is it most cost effective to send your RN in, or if the paramedic visits, is that the best use of skill level and time and talent?
Right. I think that's right. I've got a question here. It is, what are the key metrics that should be part of a contractual relationship between a home health agency and a SNF? This, I think, is an interesting question, sort of among post-acute care providers, where you're maybe it is, even, within the context of a post-acute care network, as you're trying to build relationships, are there certain metrics that, we need to be thinking about, maybe on both ends, actually? Wonder if you've got any thoughts on that, Brent.
Yeah, I think on the home health side, how quickly you can get into the home when the patient's discharged to home. I think the SNF cares considerably about that. I think they look at readmission rates from the home back into the hospital, if at all, or back to the SNF possibly. And I think they also look at the number of episodes. Is it an episode or is it two? So I think the SNF would be concerned with those factors. I think from the home health perspective, they're looking at the SNF. I think you want to work with SNFs that have a good discharge rate to community. That's an important criteria to CMS and to many payers. So are they going from SNF back to home in your care, or SNF to the nursing home? We want to see as many as appropriate. Is there an increase in functionality in the SNF? What does that look like? And then I think length of stay, because the partners that you align with, you would want them, as you are, attractive to networks. You want them to be of value. So if we're talking 28-day length of stays or 18-day length of stays, that's a big difference. If we're talking 70% discharge to community or 30%, those are things I think the home health agency, and then the functionality piece too, to ensure that you're getting in line with partners that are of high quality.
Right. I like the way you think of it, sort of, some of it might be utilization related, and some of it might just be, where that patient is going as sort of an indicator of quality. One of the trends that I think we're starting to see pick up momentum is just purely interest in Medicare spending per beneficiary. And, I don't know if you've seen this, but there's a post-acute care value-based purchasing bill that's being discussed on the Hill right now, where basically it would supplant all of the different post-acute care provider value-based purchasing programs, supplant those programs, and make the only measure Medicare spending per beneficiary. And which, to me, actually, I can understand, of course, we all understand the interest in trying to reduce costs, but as I think about it, efficiency is not purely about cost. Efficiency is supposed to be about the quality of care that's delivered for the cost. There are two elements, actually, right?
That's exactly right.
And to look at it just at spending, I think it's really kind of a scary thing from a quality of care and patient care perspective. I'm wondering, because you've done a lot of work with, managed care organizations, maybe in particular, are you seeing an increasing pressure that's just purely around cost, to the extent that it might even be, at the expense of quality, or do you see that it's a little bit more balanced?
Well, I see a trend, actually, the reverse. The bill was news to me, thank you. But I think there's a heightened concern that it used to be more just about cost. 1-800-NO being the case managers at the HMO's job. But I see the movement now towards wanting a good cost profile, but these quality indicators of readmission or outcomes or patient satisfaction, from the managed care perspective, they so impact the reimbursement from Medicare that the Medicare Advantage plan gets, their ability to have open enrollment. So I see that there's a heightened interest on the outcomes quality side, and it's a little bit movement away from pure cost, which has been more of a traditional approach. Because some of the incentives have been built in that if you don't look at your outcomes, it really negatively impacts the Medicare Advantage plan. And they're under a lot of pressure right now with the medical loss ratio limitations and the ability to profile and manage risk on the patients. They're in a difficult time, so they're really looking to ensure that their outcome metrics are strong to get any advantage they can in enrollment, premium payment, et cetera.
I mean, I think that you're right. I think especially for the Medicare Advantage, and wherever we're talking about the Medicare program, whether it's these new models and value-based purchasing in the context of traditional Medicare that are being experimented with, or it's Medicare Advantage, there's going to be a continuing interest in not just cost but also quality. That said, I think it's something for us to watch, because I think that there's such anxiety over rising costs in the healthcare system, and it's certainly understandable to want to be extremely cost conscious. We all would like to see costs go down. But like I said, I just think that the last thing that is going to be tolerable, I think, in this country is to see quality go down at the while cost is going down. And I think that's really not the preferable way to do things.
Yeah, and it's not altruism. It's a business decision for them. So I think if healthcare reform, ACA, hadn't put in place some of these other criteria for HMOs, it might become a race on cost. So as long as it's mandated that you do this reporting and your payment and ability to enroll is based upon these outcomes criteria, I think we'll be in a good place to at least work on that. Right,
absolutely. And I think that there's a lot of energy being put into the development of measures. In a way, to me, what I've been seeing is that there's definitely a lot of effort and energy on that side, but on the one hand, you've got this bill on Capitol Hill where it seems like all they really care about is Medicare spending per beneficiary. On the flip side, at CMS, there's so much energy being thrown into the Impact Act and developing measures in new measure domains and a lot of activity in QF. It's very sort of dichotomous, in fact, almost diametrically opposed, where you should have almost exclusive attention to cost on the one end, and then almost in some ways it feels like a scattershot approach at CMS and NQF, and it's nobody's fault. I think it's like what we need is a cogent prioritization and roadmap, and understanding that it's going to take time to make more sense out of the quality side, because it's both time consuming and expensive to develop measures. Anyway, so I've gotten off my soapbox now, but anyway, I just thought I would mention that.
That's a great point.
Yeah. So we've got a couple questions again, just sort of on logistics. One question is, how can we get a copy of the presentation, and how can we get a copy with the audio? So I'll just remind everybody, we're going to be posting a PDF of Brent's slides on the Alliance website after this call. So there's a portion of our website that's dedicated to webinars, and we'll post the PowerPoint slides there. And then it'll take us, probably a few days, maybe even up to a week, to get the recording, the recording plus slides, sort of the webinar recording, back from Fuse and then posted. So check back in about a week or so, because sometimes it takes a little time to get the full recording, but we will make that available too. I want to thank Brent. Brent, you've been just terrific, and you covered a ridiculously large amount of content in a really short period of time, and I know that a lot of people will find your slide deck and this presentation really helpful. So I want to thank you once again, and then thank everybody who's on the webinar today, and I'll hope that everybody tunes in for future Alliance webinars. Thank you.
Thanks, everyone. Good day.
Bye-bye.